Thank you so much, Susan. Thank you, everybody, for joining. I'm Dr. Audrey DeClue. I'm located in Ocala, Florida. If you guys are ever in Ocala, just please reach out. I'm happy to help. Come visit. Today, we're going to talk about body lameness because a lot of us as veterinarians, we get so far up on the horse's limb and then we don't know where to go. I came up with this terminology of body lameness for my clients who didn't understand axial skeleton. So body lameness is what the topic is because I have found in practice that it's not always a limb problem. So what is the definition of body lameness? It's pretty much the axial skeleton of the horse. And it's a lameness of the axial skeleton that affects the normal biomechanical movement of the axial or appendicular skeleton. This includes all the bones, soft tissue, muscles, nerves, connective tissue, the fascia, and the hyaline cartilage. So what I find is this is a whole list of clinical signs and complaints that trainers and owners have that I've heard throughout the years. It is the horse is girthy, or the horse has girthiness. It hates to be brushed. It hates to be tacked up or girthed up. Will not go forward under saddle, but it's fine on the lunge line. Cold backed, it high lows, and you'll see video of that. Hops into transitions. The canter is choppy, or it has this washing machine type movement. The horse's headset or head carriage is difficult to have a proper headset or head carriage. Its throws is next to one side. It's heavy on one rein or the other. Its haunches are fixed to one side, or simply it won't get off my leg. Trainers say it all the way, won't get off my left leg or my right. Lead change problems. It dog tracks, hangs the leg when jumping, drifts to one side of the jump. It's lame only under saddle. Can't canter on the right or left lead or both. It's hollow on one side or both, or bulged on one and hollow on the other. There's 1,000 pounds in my hand. Does not hold the ground. The diagonals are different. Push to one side. The rider's literally pushed to one side of the saddle where the stirrups feel uneven. The horse can't stop, or it's actually hopping. Veterinarians, trainer, and owners, these are the unblockable lower limb lamenesses. They're undiagnosed lamenesses. There's no engagement push, or the horse is way out behind. The horse has this disunited canter where it's in two places. I always say there's hind end here and the front end in this other county. The hind limbs, you'll see their toe dragging, stabbing, or ticking. There's chronic, over and over again, you're dealing with chronic neck, chronic back, or chronic pelvic issues that don't go away. Horses have that carpal wobble where their carcasses wobble back and forth. And head, neck, or hop. The horse actually hops versus bob that we have been traditionally trained to see. And we'll watch a video of that. There's a head wag or waddle. You'll see video of that. Horses that have funky walks. The choppy front limb stride. Asymmetry of the musculature. The horses are rearing or bolting when mounting or under saddle unexpectedly. They're tripping, or the limb falls out from underneath them. There's head tossing. The horses are above or below the neck, and the horses have either decreased cranial protraction or retraction, or the stance phase is very long or buckled. So here's a complicated case. And you might not be able to hear the video, so I'm just going to turn it down. But many people see horses like this all the time, and they don't know how to deal with it. You're looking at this video and you're going, okay, what is going on here? This horse is bulging its right shoulder right now, and it's high-lowing. The right leg doesn't come up, and then what is that?
As soon as you try to guide him.
And so I'm talking to the trainer as soon as he's trying to bend him, and then watch right here as he tries to bend him left.
That gets really stuck.
And so what I'm saying to the trainer in this video is that the left front is getting stuck down.
It doesn't come back.
And what you'll notice is that here he looks fine, but look how stabby, and whenever he does this hopping thing, it's affecting the complete biomechanics of his entire axial skeleton. And there he's high-lowing. The right leg is low, the left leg is high. And he's so toe stabby behind. But I see horses like this all the time. Draft horses, horses under saddle, maybe not this extreme, but you're questioning, like, where is the problem? And where the problem is the damage caused up here in the nuchal ligament, in the thoracic spine, at the withers, caused by equipment. This is a very common thing that I see in draft horses. It's a very common thing in riding horses, but you see how biomechanically this horse's entire axial skeleton is affected whenever he cannot pick up one or both front legs. And you got to question, okay, what is happening here? Here's another video just to let you know how often and serious I see this. This is a whole draft up horse lineup of 15 draft horse hitches. These are a 6-horse hitch. Watch these horses when I start the video. All of these horses will throw their neck up and down and to the side. And this is all caused by equipment. And so as these horses are in a lineup, you just see all of this head tossing. They're throwing their necks to the side. All of the hitches are doing it, except for one hitch here. And that hitch is my hitch. I have a hitch in this lineup. But if you look at the whole entire spread of all of these horses, you'll see that from here all the way down to here, all 15 hitches, well, 14 hitches, all of these horses are throwing their necks up and back because of the damage and the pain due to the show collars and the equipment. And also, these are the bulges and the damage that's happening from the equipment. Here's another horse. This is a very young horse. He has the same condition where he starts hopping. He's a very, very talented young horse, but he was just purchased by my client. And this is what we got. Same damage, same problem. And this horse is actually in a harness here. So you can see he doesn't have a collar on, and he is still hopping and still lame and breaking stride. Very, very talented horse. Sue Dyson published this paper in 2015 on idiopathic hopping and forelimb lameness in horses. This is an earlier case that I saw. It is a mare. It is a mare that is hopping. You see that when she goes around, she literally has her head set up. She throws her neck to the outside, but as soon as she starts to bring her head up, she does this hopping. And I'm explaining to the owner what's happening with this horse. This horse was very dangerous. Literally, they had to throw the rider up on her back to get into the show pen. And then the mare just started quitting and not wanting to show. Here's another video of her going the opposite direction. Watch when she puts her head down and then up. She cannot bring her right front leg up and forward, but she's going to do it over and over again. Now she's going slow, up. So what is happening biomechanically? What is causing these clinical signs to make a horse do this? And those are the questions that I have had to figure out over and over again. It's repeatable. Here's another horse. Watch right here. He trips, and then see how he hangs his left front leg. He literally cannot pick up his left front leg to jump square. This is very common in jumping horses. This is what I used to do for a living. And to solve problems, we call it troubleshooting. As a journeyman lineman, I'm still a journeyman lineman. I think of this as a line schematic. That's how I solve problems. I go back to the basic fundamentals, just like basic fundamentals of electricity. But we have clinical signs as veterinarians that we see in our patients. The owner and trainers call us in because there's lameness. For me, I look at this like, what are the biomechanics? What are causing or creating the clinical signs? And you break that down, you realize I have a biomechanical problem. And so you break that down into the knowledge and you realize it's a movement dysfunction. Is it in the limbs? Or is it in the axial skeleton? Or is it both, which is most important, that you need to recognize that most of the time, a limb problem is very simple, but an axial skeleton problem affects both. So then you realize you have a movement dysfunction. You have to look at the physical clinical exam, your physical clinical exam. And most importantly is how they ride and how they feel to the trainer or the owner. And then you break it down into sections. And we're going to go through that. But the problem is that people, we as a profession are trying to solve these problems at the problem level, instead of seeing it as the solution before it's too late, before these horses are girthy, before they become behavioral, before they start bolting off and everything. So we as a profession, I feel like we need to do more troubleshooting. And I just give this an example of how my brain thinks so that maybe it can help you too as a veterinarian to be able to solve these problems. Because biomechanically, we need to look at what's functional and what is dysfunctional. And that means what is moving, what is not moving, what muscles are on, what muscles are off to create body movement, and that dysfunction or function of how the body is moving. So in body lameness, there's 3 categories that I've come up with. You have true body lameness, which is only one body section affected, which is primary, say the neck or the pelvis. And then you have body lameness that's secondary, that's radiating up from the lower limbs. And that can affect 2 or more body sections, depending on the front end or the hind end. Then you have positional lameness. It is seen when the horse is under saddle or on a lunge line, and it holds its body into a certain position. It has a very abnormal body carriage, and we're going to see videos of this. Or this is why I feel like it's worse with positional lameness. There is no movement, or the body is just fixed in a certain position. And then we have compensatory lameness, which is what I feel like a lot of us see as veterinarians, is that it's multi-limb. You start blocking, it shifts around, it goes everywhere, and it's difficult to differentiate which limb or body section is affected. And one thing I can tell you guys is what I've learned through blocking horses and everything, when it starts shifting, then you really need to start looking up higher. Because when they start swapping around, it is the body that actually controls the limb movement, not the other way around. The limbs do not control the body controls the limbs. So this is a horse. I know this is a very simple schematic, but it's very, very important, because when I started drawing these things out as a journeyman lineman, not as a veterinarian, I started realizing that there's 3 sections to the horse. There's the first section, which involves the head and the neck. It's the most mobile area of the horse. This number 1 can move over here all the way to number 3 and around, and it can go dorsal, ventral, and all angles. This is the most mobile section of the horse. And this section right here, the cervical thoracic junction, allows that to happen. The second section is the thorax, the rib cage, the sternum, and everything involved there. It's the least mobile section. The thoracolumbar junction is the least mobile. There's some dorsal ventral flexion, but very little. And the lateral flexion is actually through the rib cage. The third section is the lumbar, pelvis, coxofemoral joints, and hind limbs. That third section, the lumbosacral junction, is the second largest mobile moving section in the horse. This is where the engine is. This section here, this lumbosacral junction, is the powerhouse, is the engine of the horse, and the most important. And that, the way the lumbosacral junction works is flexion, extension of the pelvis, just like this if this was a lumbar spine. This is actually a line diagram that I made of a horse in 2008. This is the original one. I was riding a horse, a client of mine, and I couldn't figure out, and this is actually the horse, this is actually what I drew. Every time I put my left leg on this horse, his whole haunches would go over here. And its head and neck was tipped to the right. And so I'm like, this is how a horse works. This is it. So I drew this all out. You can see I got the scapulas, the front legs, everything. Here's the lumbar spine. I mean, it's not schematically correct, but I was doing the best I can. And when I realized that anything off of this midline, and you have to know where the thoracolumbar junction is. You need to know where the cervical thoracic. Anything off of this straight line is where the problem is. So if the horse is holding its neck over here on this dotted line, this is where your problem is. If its haunches are fixed over to the right, this is where your problem is, and this is where your problem is. And so by doing these line diagrams, I copied this into a format, but then I just started doing this. I just drew a straight line and figured it out as I was riding the horse. And so a lot of horses are like this. They're hollow and bulged. And why are they? And you have to look at these sections. This is why I have this circle here. If the neck is out here or the haunches are over here, it's because these muscles are contracted. And if you look at anything off the straight line, it's going to give you the answer where the problems are. But today, what we're going to focus on is just those first two sections, the cervical thoracic, the head and neck, and the thoracolumbar junction, everything cranial to that, the thorax, the rib cage, the sternum, the scapula, and the front limbs. We're going to talk about this section. And I have to give credit to Dr. Beth Biles. We came up with this terminology called CCSG. It's a lot easier to say. Cervical thoracic costello scapular girdle. This encompasses that whole, for clients, I call it shoulder girdle region. Horses don't have a clavicle like we do or dogs do, but it's this entire section here. We're pending research. We're getting, I'm actually getting this ready to send off for publication. It's a retrospective study from 2022 to 2023 with 5 veterinarians that are all private practitioners. We did the same shockwave protocol that I came up to treat CCSG injuries. And here's the list of people. This is the region that I was talking about in the CCSG. And here's the data. We did 301 horses, sorry about that, 301 horses of all disciplines. The highest number was dressage, jumping, Western pleasure, those type. You can read it. Also included in this was military caisson horses at Arlington National Cemetery at Fort Myers in Washington, D.C. The largest number, the biggest complaint was girthiness. Front limb lameness, choppiness, behavioral, refusal to move forward, decreased cranial phase, asymmetry of their movement, collar or region pain, behavioral under saddle, rib pain, lameness, bulging, carpal wobble, bucking, wither sensitivity, all this stuff. You can read through this. All of these are clinical signs that we, us 5 veterinarians, wrote down as for all of our patients that were part of this study. In the treatment, we did more bilateral treatment versus one side. The location, it's very interesting, of those 301 horses, the scapula and the nuchal ligament, and we use this term shoulder girdle, the entire region was included when we just did the whole entire region, the thoracic spine, cervical, costochondral junction, sternum, and on down. We included everything that the clinician had shockwave during that visit. The trode size that we use of the PulseVet shockwave was a 35 millimeter probe, the most. We also used the 20 and the 80. And this is important because the pulse count that we use for each treatment, the highest number was 400 pulses to 1,200 to 2,000. That included the entire treatment. The energy level that we used was, with the main thing was the 35 probe and other probes, but at E2 and E6. E7, 8, and on down with the other probes was still not as large as with the 35. The frequency that we used was 180 pulses per minute, 59% of the time, or 360 was the largest numbers. The treatment sessions, now this is very important with these 301 horses, is that the number of treatments to resolution of clinical signs was 1 treatment. The second, some horses had 2 treatments and other horses had 3. So if you get on top of these problems very early, you can resolve it with 1 treatment, which is money saving for the client, which enables the horse to go back to competition sooner. Response to treatment, again, there was 100% improvement in most of the horses with 1 treatment. The behaviors resolved. There was a change of equipment, which I feel is the most important thing. There was also 90% improvement on down the line. All of these clinical signs became better after shockwave in the majority of patients. Now, this horse here I put in, it's just a saddlebred, lovely mare. She strictly has hind limb body lameness, which you can see this toe stab, toe drag. I wanted to put this in so you can understand what I'm talking about and see how she leans on the circle. And that's not from the long lining. That's actually how this mare has to carry her body. But this toe drag and toe stab is on the third section that can be treated and resolved quickly. And that's what I did with this mare. Here's another one I'm talking about the head hop, not the bob that we have all been taught as veterinarians. You watch this mare and try to figure out which leg is actually affected when she hops up. You see her neck go up and not bob down. Which leg is affected here? And this rider that's a trainer that I work for, we ask him to change his diagonals here. And you can see which leg is affected that creates that hop. And watch when he changes direction here. Now he's going to be on the outside. And look how that smooths out. Not so apparent. So whenever I'm evaluating horses, I have people, when they change the diagonals and when they move, like watch where as he bends this horse here, it starts coming back. So the left front was affected on this horse. And if you can rewind this, please watch this closely, because as the leg is coming forward, the horse's head has to hop up. And the real question is why? Why? Here's an example of positional lameness. This horse on the lunge line, this is how he has to carry his neck. He throws his neck way to the outside on both directions. So where would you say that this problem is? On the straight line of horse, where would be the problem? And the answer is the cervical thoracic junction. That whole region includes the neck, the scapulas, the thoracic spine, the ribs, the sternum, everything. You cannot exclude anything in that section. We see this all the time. We see horses that are girthy, that when you bring the pad out, even the pad out, these horses are acting like this. They're extremely painful. Sue Dyson has done the ethogram studies with horses ridden under saddle. Exceptional studies. So much respect to Sue Dyson, but we need to do pain ethograms for when we're tacking up and girthing up these horses, including in FEI, including in all disciplines before these horses are going out there for competition. Here's another young horse, and I'm explaining to the owner the reason why this horse is so behavioral is because of the girth and the cutback saddles that they're using on these saddlebreds. You can see he's standing wide base. It's a very common thing that I see, very wide base stance. And I'm talking to the trainer and saying, watch what happens. I'm loosening the girth right now. That's why the camera went away, my phone. And watch what happens. I undo the girth. You can see the girth there. And see, he just shifts back and is normal because it's the tension of the scapula, the pressure on the scapulas and the thoracic spine that creates this wide base stance. Head shaking syndrome. I have 86 cases of acute head shaking syndrome that I've resolved immediately, and not just myself, but other veterinarians that call me to help them out with cases of head shaking. If you get on top of shock waving head shaking horses immediately when the clinical signs occur, you will resolve the clinical signs. This is actually, a lot of horses have nuchal ligament displacement. It's not recognized by our profession very often. This is what it looks like. This saddlebred actually is owned by 3 veterinarians, a mother, father, and a daughter who is now a veterinarian up in Minnesota. 4 out of their 8 horses, saddlebreds, had head shaking syndrome that was resolved with shockwave and injection protocol that I do on these horses, but mainly the follow-up is shockwave. Here's another case that I hate seeing these cases. It breaks my heart. This was owned by a client of mine's granddaughter who was purchased. They did not know that this mare was not laying down and sleeping. She is a sleep deprived and collapsing horse. And we have so many cases of this in our profession. And the problem is that this nuchal ligament, and here where the thoracolumbar fascia is behind where the saddle sits, the bungee cord is all stretched out. The bungee cord of the nuchal ligament and the fascia is all damaged. And it doesn't, that's why the horse's neck drops down. That's why the stay apparatus unlocks. If you can treat these horses early with shockwave, these horses will not experience these clinical signs. It's just the fact that we all need to recognize these clinical signs and please do something about it. Here's another case. This is Dr. Beth Biles. This is one of the horses of many of the 62 horses at Arlington National Cemetery. I'm going to play that again. These horses were damaged severely, severely by 18th century equipment that they were using. Dr. Biles actually asked me to come in and help her with the body lameness issues that she was happening, but let me play this again. Because it's very, very troubling that you can put a horse to its knees by simply putting pressure there in front of its withers. These are also pictures of the horses that when I was there, I took of all the damage was present in the caisson horses. This program was actually shut down by Dr. Biles and myself, and it's been a couple years, and they are reopening it, and everything has been changed, and the program is developing into a better program for all of us. Here's another case of body lameness. Now, look at this horse and go, what is going on? I mean, that's usually what people think. What the heck? This horse was blocked out, could not figure it out. Let me show it to you again. Which leg biomechanically cannot move? Which is more affected, I guess you would say, in the front end. Both front limbs are affected, but the left front cannot, she cannot pick up the front left leg and bring it forward. Here's her going the other direction, a little bit easier, but you can see that the protraction of the left front is very, very difficult for this mare. And then when you ask her to bend, then she wants to take off a little bit. This horse is actually owned by a veterinarian, a small animal neurologist and surgeon on the East Coast. She was worked up extensively, MRI, everything. This mare had shivers in all four legs. This is why her name is Dr. Daniela. She reached out to me because this mare actually had shivers in all four legs. But after shockwave treatment, you can see this mare couldn't lay down. The shivers was a different thing. I treated her for shivers, and that's completely resolved. But that was why she couldn't lay down here, was because she had had a pasture injury a week before this. And then we had her shockwaved, and then she could lay down. And she has damage. And the next video will show you, this is this mare moving. This is why she couldn't lay down. And if we see horses that walk like this funky walk, and why are they walking funky like that? That's the real question. And she has this decreased, choppy front end movement. A lot of horses are like that, and we're not recognizing it. This is another funky walk that I hate to see, but so many of us see. It's this pop, unlocking of the stance phase, and very short strided. Here's another horse. This is actually my own horse that I purchased from another veterinarian, that buckling over, tripping, that they can't bring the leg forward. Everything is so dysfunctional. But if you look at this horse, look at this sweat pattern here. And this is only a 5-year-old cutting horse. Very, very sweat pattern here, and only through his rib cage here where the girth in that lies. This horse, I bought him, didn't even ride him. He's still in the process of rehabilitation. Here's another case that is a veterinarian's horse, veterinarian riding this horse. This horse has this head wag, waddle, but also we see it so much in the Western pleasure world. It's not normal, of this bilge pump type movement. And you can see this horse just kind of his head waddling, just waddling, and he's doing his job. It's a great horse. This is in 2023, and at the end of 2023, this horse kind of broke. And she had been to all the top veterinarians. sports medicine veterinarians, but when she comes around here, watch how this horse's neck is just waddling and wagging. There is no control of that. If she tries to take up in the reins, it gets worse. And this is all the damage that's happening in the CCSG region. But it's making sure that we are aware of these problems and seeing these problems like this atrophy here, these bulges that we're seeing in the nuchal ligament and the damage caused by the equipment. And actually, this funky color, this is actually a Grand Prix horse that I saw, and it had this funky color, and it's the entire CCSG region. We see tons of necks looking like this in practice. We ignore it. It is clinically important. The same thing here. This is actually one of the caisson horses. Due to the equipment they were using, you can see this edematous line at the cartilage bone interface if you take the x-rays, but this serpentine withers. The bone should not be serpentine in the withers, the dorsal spinous processes. And that was all caused by the collar caps and stuff they were using. This horse, the ribs, you got 3 ribs here that are asymmetrical. They were broken and remodeled. The same thing with facet remodeling and kissing spine, which we all know. But seeing this ridging in the horse's back is a glaring sign to me that there is pain there. This asymmetry, where you have complete separation and inflammation of the scapula and the scapular cartilage, which is enlarged and bulged. And you can look at this from the side. Sweat patterns. Sweat patterns tell you exactly where the problem is. So this horse here, I would shockwave here, and I injected its lower neck, and the sweat pattern went away. Look at this horse. See this bulge here? Especially here, yes, he's asymmetrical here, but look at this. This is caused by equipment, by the girths and the atrophy here. Same thing here. This is a cool case, actually. I never seen a horse with a pattern like this, but I shockwaved it and it went away. This horse actually left and got sold, and I couldn't take a follow-up picture. But same thing here, this severe asymmetry and notable sweat pattern. So again, it's a review of what's moving, what's not moving, what muscles are on, what muscles are off to create body movement. Now, do we know, everybody says that horses have shoulders, like the barrel racer will come and say, it's in the shoulder. The Western pleasure trainer will say to us as veterinarians, it's in the shoulder. The owner will say, it's in the shoulder. We as a profession, you never hear anybody diagnose a scapular problem except if the horse has Sweeney. But horses do have scapulas, and horses do have elbows, and they have ribs, and they have costochondral junctions, and they have sternums. And if we're excluding all these structures, because they are all responsible for the CCSG region, especially the largest moving bone and structure in the front end is actually the scapula. And we as a profession, we are not even recognizing this. And scapulas have to rotate back and forth for the limb to actually go forward, backwards, or have a stance phase. So all of these problems are happening. The scapular cartilage is getting damaged where it's eroded away. There's corrugation, there's thickening, there's edema that you actually can see on actually bone scans or on x-rays. The fascial attachments behind it where the scapula is attaching to the body wall. And it's the origination, all of that's the origination of a structure that nobody talks about either, is the dorsal scapular ligament. And all the surrounding musculature, we need to be aware of all this. And here's a prime example of, this was a dressage horse that I necropsied. This is the erosion away, and you can see how corrugated and how thickened the scapular cartilage is, completely eroded away. And this is actually a 18-month-old horse that I euthanized, had septic joints, had a bad septic joint. But look how smooth, and let me play this video. Look how beautiful and smooth this cartilage is supposed to be. But these are the structures that are getting damaged, and it's very, very painful for the horses. Awareness, these type of indents inflammation. You can see the damage that's happened here, especially here where the girth lies. This horse, this distinct line in its rib cage. This is actually it was a big Grand Prix horse that I got called in to consult on, and this was the problem. I just walked up and I'm like, oh my God, that's the problem. That's easy. The horse was actually bolting off and wouldn't even go in the ring. But we shockwaved and treated this horse, and the horse went back to competition. So the ribs and the rib cage, we negate that there's problems there. We have to remember that there's intercostal muscles between every single rib. There's a vein, artery, and nerve. There's fractures, displacements, and bruising that happens. And there's also compression atrophy of the musculature of the intercostal muscles, but also everything on top of that. And it's just seeing this stuff and being aware of it. And the best thing you can do if you see these things is to shockwave it. It will resolve these dermal constrictions and fascial constrictions. And then when we necropsy these horses, it's actually adhered down to the body wall in the latissimus dorsi and antebrachii muscle. So please be aware of this. Same thing, costochondral junctions. Nobody talks about it in sport horses or in horses, and the same thing with the sternum and how it is as a keel. There's a lot of severe pain. There's actually, it looks like a keel. There's a fracture here in the sternum. This is what it looks like on bone scan when the costochondral junction. Here's the right side, here's the left side. You can see that the costochondral junction is actually hot on this bone scan, and along with this side of the sternum versus this side, the other side of the sternum. These are the deviations that we see and swellings along, same thing with here. This is not a hematoma. This is actually severe atrophy caused, and the same thing here, caused by girths and equipment. Here's a current case I'm working on now. This is a 3-year-old quarter horse that got injured. Nobody could figure out what was wrong with it, but he walks this very wide-based, and you can see this saddle mark up on top on the left side, but he walks this wide base. He's got a severe sweat pattern here, and he will not move forward. I mean, this is a 2-year-old horse. He should be running around crazy. This is what he looks like when he's moving. This very wide-based, will not go forward, can barely bring its legs forward. You see that, again, the saddle mark, and this is a 2-year-old horse coming 3, just will not, and there he's lame on his hind end too. As soon as he brings his neck up, you got to understand that when there's axial skeleton problems of any of the sections, it's affecting the entire biomechanics of the horse. This shows you the actual saddle mark and a small sweat pattern here and here. And then these are actually the radiographs. You can see this edema, this edematous line up here. Everybody will ignore that, but it is actually relevant. And again, it is the curvature of these dorsal spinous processes that is, people will say it's normal, and I'm going to say it's abnormal, and I'm going to treat that. Same thing here as we look down. These are the dorsal spinous processes, normal space, normal space, normal space on this horse, but this is narrow. And this is back behind the scapula. Same thing here as we go caudally, normal spacing of the dorsal spinous processes. But when you look here, it's in the same spot as where these dorsal spinous processes are deviate. So you got to understand there is an injury pulling those spinous processes back. So what are the causes? I mean, that's most important. What is causing this? And it can be acute injury. It can be subacute injury. It can be a chronic or undiagnosed injury. The number one thing that I see that creates these problems is actually equipment. The equipment that we're putting on these horses, as this is, shows a horrific saddle fitting. The collars, you can see this white mark on this draft horse. The same thing with these girths, the mohair girths that have no protection of the Ds. And all these girths creeping up, putting pressure on the antebrachii muscles, the sternum, the elbow, the latissimus dorsi, everything underneath the ribs, so that as the leg is moved, it's affecting it. But you also have to rule out like internal medicine problems. you have to rule out ulcers. You have to rule out dermatological issues, and systemic don't feel good issues also can affect horses and create signs of CCSG. There's something else I want to talk about is blankets. I deal with this a lot where blankets are too tight. They can actually worsen the clinical signs. A lot of times when you start blanketing horses in the wintertime, you'll see that the horses, they're like, oh, my horse starts getting really choppy in front, or it's throwing its neck up now. Those clinical signs are important to me. Please be aware of blankets. They need to fit properly. One blanket type doesn't fit a quarter horse versus a warm blood versus a draft horse. You need to, just like us, you need to properly fit blankets to the horse. This is kind of a funny video, but this is my cutting horse. He's passed away, but a really great cutting horse I had. You can see he has these white saddle marks. He came to me that way. He had CCSG injury. This is actually the second time I ever rode him bareback, which is not the smartest thing because he's a very, very quirky horse. But this is how I had to figure it out, because I knew that these white spots would help, but this horse was very downhill. And I have a GoPro, and this is on a Sunday morning. I'd cut on Saturday, and I'm like, I got to come out here and do this. So I actually got on bareback Saturday, so to see if he would tolerate it. So I'm in the arena by myself, and let me show you this. I turn up the volume so you can hear me. No, come on, let's walk. So what I'm doing here is I'm watching the scapula. I'm watching how this is moving, which side is moving different, which side is abnormal, which side is normal. At this point, I don't know, to be honest with you. I didn't know then. I was trying to figure all this stuff out. And I've ridden some other horses bareback, but I just hadn't figured it out yet. So I'm going to continue the video. Come on. No. This way. No. Hey. Come on. Move. Oops, sorry, my fault. Come on. Jesus. Come on. No, walk. Oh, come on. I know you feel like I'm gonna fall off. Come on, walk. Okay, that wasn't nice. Come here. Whoa. Whoa. So as you can see, how downhill he is. Whoa. So then he looks at me like, you shouldn't have been up on top of my butt. And you can see how downhill he was because I was sliding. So anyways, these are the stupid things that I do to figure this stuff out. And I still haven't learned from my mistakes, because this is that roan horse. Still, this is last month, literally. At least I put the bridle on the horse. I don't know why the lead rope around his neck was going to help me any. But this is the 5-year-old I own now. And you can see, like, look at how the scapulas are moving. And here, when I ask him to turn, we need to be aware of this stuff. And I'm asking him to turn left and see how that left front gets caught. It's the same left front leg that couldn't come forward. Okay. Watch when he's walking forward. Look at this side versus this side. It's asymmetrical. This is not a lower limb problem. It is not a blockable lameness. It is all up here in that CCSG region. So how do you diagnose this? Please don't ride the horses bareback. Please don't do stupid things that I decide to do to figure this stuff out. It's not smart. But it's your clinical exam, range of motion, and palpate the horses before, but the most important thing is palpate these horses after exercise. You need to see them move at all gaits, with or without equipment, and also under saddle. The diagnostics that I use is radiographs, ultrasound, bone scan, and CT. But for me personally, this is in my clinic. All I have is an ultrasound and a pulse vet shockwave. That's it. All the radiographs, everything else, I refer out to other veterinarians and practices. There's clinical research in 2022. This is a human paper talking about all the benefits, musculoskeletal benefits to shockwave in humans and human athletes. You can look this up. This is my shockwave protocol. This region here, you want to make sure you stay around the bone. Don't shockwave over the scapular bone. It's very painful to the horses. Take my personal experience from doing it and making horses very lame. But the nuchal ligament area region, including going all the way up the neck and this entire region. What is the starting probe that I use in energy? It truly depends on my clinical palpation and range of motion. And one thing I can tell you, and please, more is not better. I usually start at the 35 probe at a very low energy. The key is to move lots of gel. You have to have gel, and the horse cannot be hot. The horse has to be cooled down so that the gel stays on the horse. I have an air conditioned clinic. It needs to be in a cool area. If it's out in the sun, it's just going to melt off. You want to start with a low energy. The number one and two was E2 or E6. So I usually start at 35 millimeter probe at E1 or E2 with these horses. And the key is just to move the probe around and find the areas that are sensitive to the horse and painful to the horse. Sedation depends on the horse. If it's a saddlebred that I'm doing for the first time, definitely sedation, right? Or a Pasifino, definitely sedation. So please use your own clinical experience and common sense to make that decision. The pulses, I usually start very low at 5 to 800. So if I'm doing this region, I'm going to do probably 300 here, 500 through here, this region, and then 300 through here. So, and at different depths and frequency and also pulses. So it's variable to me. I search around and try to find the areas that are painful, and I treat that region, but moving around. The frequency, it's depending on what type of depth you want. And again, this is a reminder. This purple thing is here to say, don't do this area. You can, but be careful and very low. But this is all the attachments and everything of the CCSG region. Post-treatment, this actually, Dr. Brandy Ashman treated this horse with shockwave before and after treatment. And it's not just in my hands, but all veterinarians can get the same results if this is diagnosed early and treated early. Within 1 or 2 treatments, these horses can be back to normal. But if it's a chronic injury, it's going to take more and more. The protocol that I do post-treatment is no exercise or equipment on the horse the day of the shockwave, and no equipment for 2 days. And where I want the horse only lunging at a walk and trot only, no cantering. I want everything to move symmetrically. Rehabilitation and physiotherapy, everything. Stretching, myofascial release, acupuncture, laser, PEMF blankets, beamers, chiro-osteopathy. Any of these things will also help in correlation. I took this picture after I shockwaved the saddlebred. You can see on these cutback saddles where there is no movement here. I despised cutback saddles because of this. It digs into the caudal aspect of the scapular cartilage, creating horrific damage to these horses. I see so much high-lowing and damage in saddlebreds and Morgans, the show saddlebreds and Morgans, because of these cutback saddles. The take-home message is, number one, recognizing the CCSG clinical signs, the patterns of CCSG and its biomechanical movement, and also the causes regarding equipment, and recognize if the treatment occurs immediately with shockwave, the resolution of the clinical signs will resolve within 1 or 2 treatments if you follow these protocols.